Good afternoon, everyone. We're just going to give it a couple of minutes and then we'll get started. Excellent. We might actually make a start because most people have jumped straight in, which is great. So good afternoon, everyone, and welcome to the Australian Primary Care Nurses Association and Northern Queensland PHN webinar on the basic principles of infection prevention and control. Just before I get started today, I would just like to acknowledge the traditional owners of the country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures and to the elders past, present and emerging. So my name's Sarah Drew. I'm the Nurse Programs Manager here at APNA and I'm the Manager of the Infection Prevention and Control Helpline for Victoria. I'm joined this afternoon by Megan Reilly. Megan is our subject matter expert on the helpline. She's also the director of the hands-on control infection control, and she is a registered nurse in IPN. Megan will be taking us through the main component of the presentation this afternoon. So what are we going to cover today? We're going to talk about the basic principles of infection prevention and control in order to keep you safe and open for business during what is our pending COVID impact in Queensland. Megan's going to talk you through all of those principles and the sorts of things that you should be considering and adopting as we move forward in this space. I'm going to give you a few hints and tips of things to take away, a little bit of an update from North Queensland PHN and how they can support you through your processes and through the coming months. We're going to have a Q&A. We've had some questions submitted previously, so we'll get to those. But also, if you have any questions today, please make sure you pop them into the Q&A. And then I'm going to give you the link for our evaluations, and we'll close hopefully by 1:30 on the dot is our good plan. So this is the third session of these webinars that we've delivered in collaboration with Northern Queensland PHN. And it's with their funding that they have been made possible over the past few weeks. So as I said, you've got the Q&A function. So in your toolbar for your webinar in Zoom, if you can just identify the Q&A section, we ask that this is where you put your questions, simply for two reasons. One, the chat is not monitored by myself, who is your facilitator. And so I'm not going in there and looking for Q&As. But the other benefit of that is if someone else posts a question in there, you have the ability to upvote it. So clicking on the little thumbs up will actually upvote that question to the top. So in the event that we don't manage to get through all the questions today, they will be answered post-webinar when we forward out the Q&A section to you. But we do want to keep them sort of high level and not organisation specific, because obviously there's all the contextualisation we have to put around organisations. So if you upvote, if you see something you like, that will enable us to get to those first, and then we can get to all of the others if we run out of time in what we send out to you, which will go to all registrants as well. So what are the learning outcomes for this afternoon? Ultimately, what we want to do is give you some guidelines to walk away with, the principles of infection prevention and control, in order for you to ensure business continuity over the coming months, whilst preventing as much as possible the transmission of this enjoyable virus that we've had for almost 2 years now. So Megan is going to provide you with some of the basic principles to consider. We're going to try and improve your knowledge on IPC, and we're going to explain how aspects of IPC can be utilised within your workplace to prevent the risk of a COVID outbreak. One thing that we do know is that infection prevention and control is a huge part of what we do in primary care. You know, it covers an array of things that you can see on your screen here, and it certainly includes more than what we have the capability of delivering in a 1 hour session. So today on your screen, you can see all of those components. We are not going to be talking to all of them. We're going to be talking to the critical things that are important right here, right now for you to consider, ensuring ongoing activity in your workplace. So we're not going to be talking around sterilisation. We're not going to be talking around immunisation and management of sharps and those sorts of things. But please keep in the back of your mind that obviously all of that is encompassed in this space. And so that will hopefully give you the tips and tricks you need for right here, right now, whilst considering everything else. So what I'm going to do now is I'm going to hand over to Megan. Megan's going to take us through, like I said, the main part of the presentation this afternoon, and I will be back shortly. Over to you, Megan.
Thanks, Sarah, and good afternoon, everyone, and greetings from Perth, Western Australia. Now, I suppose we can't really start a session on the principles and practices of infection prevention and control without first reacquainting ourselves with the chain of theory. So this is a conceptual model. The Americans like to call it the germ theory, but it's not really a theory, it's more of a model. And it's the I suppose the theory behind our practice. And we can see from this slide what are the 6 key links in the chain of infection and how transmission can actually occur. And each one of those links is really important. And we can apply this both to standard precautions, but also we can apply it to transmission-based precautions. It's actually a very useful tool in our armoury. So our responsibility is to interrupt or break that chain of infection. If we move to the next slide, what we can see is this in relation to COVID-19. So it very nicely describes what the chain of transmission is. So we can see the first link in the chain is our causative agent, and we know that this is a respiratory virus that causes COVID, in particular SARS coronavirus 2. Who does it infect? Well, it's people within the community who are our reservoir. The portal of exit for coronavirus is through the upper respiratory tract. So coughing, sneezing, talking, singing. We can expel droplets or aerosols through those mechanisms. The next link is really quite an important link because this is often where our basic principles and practices impact and actually interrupt that chain of infection, and that's the mode of transmission. And we know that with COVID, it's spread largely through the droplet route, but it can certainly also be spread through the direct and indirect contact route and on occasion through the airborne route. The portal of entry for this organism is through the respiratory tract, but in particular, the mucous membranes of the eyes, the nose, and the mouth. And who is susceptible in our community? Well, certainly initially in this pandemic, we were all susceptible to infection. Some of us are now less susceptible through the advent of vaccination, but we also have to acknowledge that there are some people within our community that are even more susceptible. And in particular, we refer to older people, those who are immunocompromised, and some of our communities, such as our First Nations people and our disability services clients. So as I said, our role is to interrupt or to break the chain of infection. And we can see that we can do this quite easily with COVID, even with the Delta strain being highly infectious and a virulent organism. Simple things such as performing hand hygiene, applying respiratory hygiene and cough etiquette, practicing our physical distancing, selecting and using personal protective equipment appropriately, and cleaning our frequently touched surfaces are all measures that we can put into place to interrupt or break the COVID chain of infection. So we'll move on to the next slide and just talk about the overarching principles. So what we aim to do in infection control is to prevent or minimise the spread of infectious agents between people in any healthcare setting. And we tend to utilise a risk management approach, but we're also very focused on the patient. And we know that if we engage with our patients or our clients in relation to infection control, we'll actually provide much better quality and higher standard of IPC. And we need to apply that in all of our work practices and with all of our patient care activities. And we do that in accordance with the evidence base. And where we don't have an evidence base to support all aspects of infection prevention and control, then we utilise what are considered international best practice guidelines. So really, we want to ensure that we do have effective work practices at each stage of patient care, and that really involves everyone within your business or your practice. So we often hear the term infection prevention is everybody's responsibility, which it is. Okay, if we go to the next slide. So let's talk about the first line of approach to infection control. I'm sure you're familiar with our precaution system. So our first line is standard precautions. So this is about applying basic practices that will prevent and control infection. It's adopted by all healthcare workers in all healthcare settings, regardless of whether we suspect or we have a confirmed infection or organism in a patient. So this is, again, the emphasis on reducing and preventing transmission of infection, but also to try and render and maintain objects and areas as free as possible from infectious agents. Next slide, thank you. So now our second line approach is standard transmission-based precautions. So standard precautions aren't going to be suitable for every situation. So where we have additional risk, then we need to put into place additional risk minimisation practices. So when standard precautions aren't alone or sufficient to prevent transmission, then we apply specific precautions based on how that organism is transmitted. So through contact, droplet, airborne, or sometimes a combination of those, as we see with COVID and other organisms such as norovirus, Clostridium difficile, etc. So we can just see some of the dot points there. It's some of those additional precautions that you might put into place in your business or your practice to prevent the transmission of infections, such as triaging, segregating, maybe cohorting patients with the same infectious agent, restricting patient movement around your practice, enhanced use of personal protective equipment. So when we talk about COVID, a suspected or confirmed case, we talk about the use of an N95 respirator versus a surgical mask. Dedicating equipment, looking at what our air handling systems are doing, and enhancing our cleaning requirements. And we can escalate that based on the situation that's occurring. So transmission-based precautions are very useful for managing single cases of infection, but they're also applied to outbreak situations in an effort to try and contain and prevent transmission. So very helpful is that to raise awareness around transmission-based precautions, it really does require good communication and documentation. And using standardized signage, as you can see on the slide in front of you, actually helps to raise that awareness of the precautions that are required. So if we move on to the next slide. So just to, I suppose, summarize what are standard precautions, and we'll focus on a number of these in the context of COVID. Certainly performing hand hygiene in accordance with the 5 moments for hand hygiene, selecting and using personal protective equipment based on risk assessment, in other words, your exposure, the use and disposal of sharps, performing routine environmental cleaning is part of standard precautions, as is cleaning and reprocessing our shared patient equipment. So that includes our non-critical devices, our semi-critical and our critical devices, following respiratory hygiene and cough etiquette, using aseptic technique, and handling and disposing of waste and used linen safely. So let's focus on some of these key practices. Hand hygiene, we know, is one of the most effective interventions that you can put into place in your business and practice to reduce the risk of infection. It includes the application of the National Hand Hygiene Initiative's 5 moments for hand hygiene. So this identifies critical times to perform hand hygiene in order to reduce the risk to your patients, but also to you as a healthcare worker, and to interrupt the chain of transmission. So having easy access to hands-free hand hygiene facilities for you at the point of care, but also for your patients, their carers and other visitors is very important. It's also important that we select compatible products based on the hand hygiene methods that are required. So out there in general practice and in pharmacies, we tend to focus on our routine hand hygiene, and also if we're performing an invasive clinical procedure, then we apply our clinical or aseptic hand hygiene. So our products need to be compatible with our techniques or our methods. Of course, the gold standard is alcohol-based hand rub, This needs to be TGA approved. It needs to contain the right amount of ethanol or equivalent, and it needs to meet the European standard. But we use alcohol-based hand rubs on visibly clean hands. On hands that are visibly soiled, or perhaps when we're caring for someone who has an organism that's resistant to alcohol, like some of the small non-envelope viruses such as norovirus, then we would use a plain soap or an antimicrobial soap, depending on the method of hand hygiene. The important thing too about hand hygiene is to include in your program the maintenance of your skin integrity. Your hands are your tools of trade, but they can also be your worst enemies if we don't keep them nice and healthy and intact. I certainly would refer you to the Australian Commission on Safety and Quality in Healthcare's National Hand Hygiene Initiative, Hand Hygiene online learning modules. And there are modules for allied health workers, medical practitioners, nurses and midwives, and also modules for non-clinical staff. And they focus on the 5 moments for hand hygiene, but they've actually also got a very good module on hand dermatitis that I would recommend that if you haven't undertaken one of these modules, that you do so. Moving along, respiratory hygiene and cough etiquette is a part of standard precautions. So things that we can do to encourage that is posting signage, making sure that you've got tissues and no-touch waste receptacles readily available in your practice, providing resources and instructions around hand hygiene. And these can be at the point of care for staff, but also for your patients, carers and visitors. So ensure that you've got conveniently located alcohol-based hand rub dispensers, preferably hands-free if possible. We can offer masks to patients who attend your business or practice with respiratory symptoms. Hopefully they're not doing that, but they may well actually need to attend for treatment and care. And I also include physical distancing in there. We try and do physical distancing where practical, particularly in these heightened times and as we move to opening up our borders in each of our respective states. So that's one of the other measures. So personal protective equipment. So PPE needs to be readily available in the clinical environment at the point of care. It needs to comply with relevant Australian standards, and it needs to be appropriate for the intended use. So when we're selecting our personal protective equipment, when we're procuring it, we need to make sure that we have we consider the different types of PPE that are available and also the sizes. And that's particularly relevant when we're looking at N95 masks. Not all masks, not all face shapes rather, are suitable for one type of mask size. So that needs to be considered certainly. So it is really important. We found just recently that a number of the masks that people have procured, although TGA approved, following investigation and on testing, have actually been found to be non-compliant and have either lost their ARTG status or in fact are only suitable for particular use. So it is really important that we get that right to ensure that not only your patients are protected, but you as healthcare workers are also protected. We need to select and use our PPE correctly, and we do that based on risk assessment. So the criteria is, when I carry out the task or activity, is there a probability of exposure to blood and body substances? Consider the amount of body substance involved and also the probable type and route of transmission of infectious agents. So contact versus droplet versus airborne transmission, or maybe a combination of those, such as we see with COVID-19. It is important that fit testing and checking of your N95 respirators is conducted. We need to make sure that the mask or the respirator is actually going to fit correctly and therefore be protective. Now, I am aware that the North Queensland PHN is funding fit testing training for those GP practices who responded to an expression of interest that was sent out. That training is for qualitative fit testing and it will be occurring this month is my understanding. Fit testing is actually recommended to be undertaken on induction of the healthcare worker to their place of employment and then annually thereafter. And of course, it needs to be checked each time the respirator is actually applied to ensure that there is a good seal. Aseptic technique may not seem to be in the right context with COVID-19. Certainly it's an important infection prevention and control principle, but we can see from the slide that there are actually some aspects or some practices of aseptic technique that do in fact are relevant in the context of COVID-19. So what aseptic technique aims to do is actually prevents infectious agents from being introduced to susceptible sites by hands, surfaces, and equipment in sufficient quantity to actually cause infection. So we need to be able to protect patients during clinical procedures that might be undertaken in your business or your practice by employing these appropriate infection control measures that can minimise as practically as possible the presence of pathogenic organisms. So some key principles are around managing the environment, decontaminating our surfaces and protecting them, ensuring that we've got an aseptic field, depending on the level of asepsis required, that where possible we use a no-touch technique, and we prevent cross-infection by effectively decontaminating at the end of the procedure, so the surfaces, the equipment, and the hands of the clinician. Linen and waste handling is an important part of standard precautions, and we apply those precautions whenever we handle used linen or waste. We do need to, I think, in practice, consider disposable linen wherever possible. If you're unable to meet the Australian-New Zealand 4146 laundry practice standard for reprocessing reusable linen, then it's certainly something to consider to moving to disposable linen, such as disposable examination bed rolls, disposable screens, privacy curtains, that sort of thing. Consider point of generation segregation and containment of waste. So we want to confine and contain the risk for linen. If it's soiled and it's going to leak, then we need to place it into a leak-proof bag. Use your PPE when you're handling linen and waste. Use linen and waste in accordance with the risk criteria that we talked about in the previous slide. And just look at where you're storing your waste and your used linen. Try and minimise storage in clinical areas wherever possible. Now we're just going to sort of change tack a little bit, still part of standard precautions and certainly is incorporated into transmission-based precautions, and that's the design and maintenance of your premises. That can have a really big influence in terms of environmental controls and things that we need to consider within our existing practices, but if we were renovating a practice or building a new practice, is our heating, ventilation, and air conditioning systems, but also our water systems. We need to think about, do we have the ability to isolate, to segregate, and to separate patients? Can our surfaces and fittings and fixtures and finishes be easily cleaned and maintained? Can we separate out our workflows? So we're very good at doing that in our steri areas. We can separate clean and dirty activities into clean and dirty zones. But can we do that in other areas within our practice or business? Do we have adequate storage? Because we don't actually want a lot of clutter. If we have a lot of clutter, a lot of items that aren't actually in use at that particular time, then we increase the risk for it becoming contaminated. And it really minimises the effect of good cleaning. Ready access to hand hygiene facilities and personal protective equipment, as we talked about, and also making sure that we have appropriate waste cleaning and linen handling systems within our practice. So let's move on now to environmental cleaning. We know that the environment is a potential reservoir for organisms. We know it's linked to the chain of transmission. So we really need to be identifying and managing those microorganisms or infectious agents that we're likely to see within our practice or our business. So environmental cleaning is a fundamental intervention of our infection control programs. It is part of standard precautions, but in order for it to be effective, it can't just be a standalone intervention. We need to incorporate it into other elements of our program. So it stands alongside things like governance, education and training, policies and procedures, monitoring, auditing, and providing feedback to staff and contractors who are involved in cleaning. So when we look at environmental transmission, we can see that it actually occurs by different pathways. If we could just go over to the next slide, Sarah. Great, thank you. So we can see if we have a colonised or an infected patient arrive in our practice or in our business, and they touch surfaces, they may well be able to contaminate those surfaces and other equipment, non-critical equipment that they touch. We can then see that the mechanism, if we have the next susceptible patient, the last link in the chain of infection, comes into contact with those surfaces, then they are at risk of infection. So too are the healthcare workers who come into contact with those surfaces and that equipment, whether their hands are gloved or ungloved. And then we can transfer that on to the next susceptible patient. That's if we are omitting those key steps, and in particular, hand hygiene and environmental cleaning comes into that. We know that some pathogens can survive on surfaces of varying periods, from minutes to hours to months. Clostridiosis difficile can survive for months on a surface if we don't have good programs in place. The actual survival times of organisms will vary, and some of those factors that will vary the survival time is around temperature, relative humidity, and the type of surface. So we know that COVID is largely spread through exposure to respiratory droplets carrying the infectious virus. And in most situations, cleaning with a detergent will be most suitable. That sort of has changed a little bit with this Delta strain, where we see that it is more virulent, it is more infectious, and contact transmission can certainly occur. So to reduce the risk of surfaces and fomites or inanimate objects within our practice from becoming contaminated, or if they do become contaminated, then we need to ensure that we have good cleaning. And we may have to move to enhanced cleaning based on what activity, what community outbreaks are occurring around us or within our region. Next slide, please. So how do we actually determine what our cleaning method is, our process, our frequency, our products that we're using? I like to take a risk-based approach to it. I like to look at, well, what is the probability of contamination with pathogens? What is the vulnerability of the population to infection that I'm providing a service to? And what is the potential for exposure? So that's looking at our high touches versus our low touches. And this can all be influenced by infection prevalence rate within the community, the amount of virus, if we're talking about COVID, that can be expelled. Obviously, that's reduced when people are wearing masks. The deposition of expelled virus particles onto surfaces, and we know that that can be affected by airflow and ventilation. The interaction of those environmental factors, so heat and evaporation can actually cause damage to virus particles while they're airborne or while they're on fomites or non-living objects. And also the time that it takes between a surface becoming contaminated and when a person actually touches that surface. So there's a whole load of variables involved in the risk assessment process. So now how do we determine what cleaning methods and processes should we be using? I like to refer to this table from the Australian Infection Control Guidelines, and that looks at minimally touched surfaces versus frequently or high touch surfaces. And we should then ask ourselves the question, is there suspected to be a multi-drug resistant organism or other infectious agents such as COVID present that would require transmission-based precautions? If the answer was no, then physically or mechanically cleaning with a detergent solution would be quite suitable. But if the answer is yes, then we look at the context of our healthcare setting. So if we're in a non-acute setting, like we are in primary care, then we need to consider the local circumstances, such as your patient mix, the procedures that you undertake within your practice or business, and what are the local outbreak conditions. And we can use that criteria to then assess the need for a detergent combined with a disinfectant or followed by a disinfectant. We can see in the acute care setting now we routinely clean and disinfect because obviously these healthcare environments have a much higher risk of transmission of infection because of the number of pathogens that we see. So the processes we need to determine are around our routine cleaning program, our unscheduled blood and body fluid spills management, our program for cleaning our non-critical patient care equipment, because remember these items are shared and they have a lot of contact with patients, but also healthcare workers. What's our enhanced cleaning and disinfection program? Your scheduled cleaning program, so is that daily, weekly, monthly, 6 monthly? And what is your process for terminal cleaning? So you have a patient who comes into your practice, we suspect or they're confirmed with a particular infectious condition, or They come in with COVID, for example. What is our cleaning process when that patient leaves that environment? So a documented cleaning schedule is really important. It should outline the staff responsible for cleaning, the surfaces that need to be cleaning, the cleaning method and process, and the products to be used, and of course the frequency. Other things to consider in terms of cleaning frequency, it really should be justified by the risk of transmission of infection within your practice. High-touch surfaces will need more vigorous cleaning, so that might require a different method or a different process. So we like to, in terms of standard precautions, those frequently touched surfaces should be cleaned at least daily when they're visibly soiled, but after every known contamination by a likely pathogen. Those surfaces that are subject to less frequent contact, then they can be cleaned less frequently. So the risk of transmission of a particular infection should really be assessed, and then you adjust your cleaning schedule if there is a non-infectious present either in the practice, but also look at what's happening in the community. And when we talk about COVID, is it present in the community? Is it escalating within the community? And that will assist you to determine your cleaning frequency. Also consider product, equipment and selection. So are you going to use a two-step clean versus a two-in-one clean? Will you use microfiber versus conventional cotton? Will you have a reusable cleaning system or a disposable system? Will you use solution or wipes? Will you use a detergent, or will you use a detergent disinfectant? So all of those need to be considered in terms of your products and your equipment, and of course the PPE. But I would stress that if you are using a disinfectant or procuring a disinfectant, some of the things that you need to consider. Firstly, it needs to be a TGA listed hospital grade disinfectant. For COVID, you can go onto the TGA website and identify whether your product is effective against COVID, but you can also look at the manufacturer's instructions for use and also the product information. I've just popped a little table on the right-hand side of the slide, just some of the questions to consider when you're actually selecting or reviewing your disinfectant. What is its kill claim? So what bugs can it kill? What's the contact time required? You don't want a product that has to have 10-minute contact time, because we just don't have that sort of time in practice. Is it compatible with your surfaces? If there are any safety issues around the product that you're looking at, is it easy to use? Is it practical? And do you get value for money from it? And moving on from there, think about the materials that you're going to use these products on, your fittings, your finishes, your furnishings, and also your patient care equipment. Firstly, can they be cleaned, and are they compatible with the detergent and the disinfectant products that you have procured and are using? So it does involve a decision-making process in order to guide your selection and procurement. Please refer to the manufacturer's instructions. It's really important that you follow those. So some of the things to think about with your surfaces, if you're purchasing new non-critical equipment, ask the question again, is it cleanable? Is it easy to maintain and repair? Is it resistant to microbial growth? Is it non-porous? And is it seamless? And I would refer you to the YouTube video when you get a chance, because it really does emphasize the importance of cleaning in terms of interrupting or breaking the chain of infection. And the next slide. So let's just focus in a little bit now on the strategies that you can use to minimize your COVID-19 risk and keep your doors open and practice running. Now, remember that these strategies can be escalated based on community risk and community transmission with COVID. So what is your pre-booking system? Is it online, telephone? And with that, think about your screening questions and what your infection control procedure will be when the patient actually arrives at your practice or at your business. So those screening questions can be online, they can be over the telephone, and then of course they're repeated once the patient arrives at your business or practice. And some examples of screening questions include, do you have a fever, a runny nose, a cough, a sore throat, or loss of smell or taste? Are you or a family or household member awaiting a COVID-19 test result? Have you come into contact with a confirmed case of COVID-19 or someone in isolation or quarantine in the last 14 days? Have you visited an interstate or New Zealand red or orange zone, or low, medium, high or extreme risk zone if you're from Western Australia? Have you visited an identified exposure site in the last 14 days? Have you arrived in Australia from an overseas location in the past 14 days? And have you visited or worked in a quarantine hotel or international port, such as an airport or seaport, in the last 7 days? So there's some of the common screening questions that we can be asking our patients or our clients. And of course, we rescreen when they arrive at your visitor, but we need to be thinking about visitors, carers and contracts who also enter your business or practice. Can you minimise people in the waiting areas? We can be quite creative and alternative in terms of where people need to sit, excuse me. So can the patient actually wait in the car and then when their appointment time, they can be called in? Can you restrict attendance time? So keep it to a short practice, a short attendance time rather than a longer consultation. Can you limit the amount of people present in that consultation to the patient and maybe one other significant person? Are you able to dedicate and separate out your pre and post waiting areas and also your vaccine administration rooms? Physical distancing where practical. So think about where the patient chairs are placed in your waiting areas. The physical distancing between staff and the patient, unless of course physical contact is required. But think about your reception areas and greeting on entrance, and mask wearing by patients and staff. So the use of PPE will be very dependent on community risk level and the patient category. If we're treating a suspected or a confirmed COVID-19 case or during known community transmission in your area, then we need to refer to the PPE guidelines. And this next slide actually is the table 3 out of the Queensland Health Pandemic Response Guidance. And you can see that it looks at low risk, moderate risk and high risk locations. And down the left-hand side, it looks at your patient or client category. And again, that's risk-based. And then we can determine what level of PPE we need to be wearing depending on the risk situation, but also the PPE for patient use as well. And that is quite a helpful guidance for you. I've also popped onto the slide this next diagram, which looks at the assessment of level of exposure risk to COVID. And it divides it into higher risk and lower risk. And sometimes this is a useful tool, but this has come out of the National COVID-19 Clinical Evidence Task Force. So we can see that if we're caring for an individual with confirmed COVID-19 or individuals with epidemiological risk factors with or without symptoms, or if we're caring for individuals with no epidemiological risk factors, but they do have symptoms consistent with COVID and there's known local transmission, then that's considered higher risk. And therefore we need to be wearing full PPE as opposed to lower risk. So we're always looking at the health status of the individual, the epidemiological risk factors, and then we're looking at what is happening in the community as well in terms of transmission. Okay, moving on to the next slide. So other strategies for minimising the risk: displaying your hand hygiene, your respiratory hygiene and your physical distancing signage. Good reminder for everyone, making sure that you've got your hands-free alcohol-based hand rub stations, tissues and lined waste bins available. You can install sneeze guards or barriers, increasing your cleaning and disinfection. And remember, this will be an escalation measure. So look at your high-touch surfaces. You're using a TGA-approved agent. You can look at the frequency of your cleaning. So it may well be where we have community transmission that you're increasing your hourly cleaning. Your high-touch surfaces are going to be doing more regularly. And think about the staff shared workspaces as well. Can we physically distance those, but look at the frequency of cleaning those, particularly those shared surfaces. Environmental management, so we need to look at our controls. So is your ventilation adequate? Can you increase the amount of outdoor air by opening windows and doors if it's safe to do so? And that will certainly increase the outdoor airflow. Do you know what your ventilation, does it meet the indoor space requirements? How many air changes within particularly your clinical, your treatment rooms and where your patients are per hour. So we will look at sort of 6 to 8 air changes as being helpful. And think about the communal surfaces and items. You know, can you remove the toys and the magazines and you know, if you have a water cooler that has to be touched? Can you introduce alternative or separate entry and exit points wherever possible? And of course, one of our key strategies is rolling up and getting vaccinated. So that's a whirlwind trip through infection prevention and control principles and practices, and applying it in the context of our current situation with COVID. So what if you have identified some gaps? You know, what action can you take to address those gaps and meet your infection control obligations? Important to continue and to maintain and update your knowledge. And I would certainly recommend that you regularly undertake some sort of infection control course. Certainly the Australian Commission on Safety and Quality has a series of modules that are free to participate in. And I would certainly recommend that you have a look at those. I'm going to hand you back now to Sarah to finish off.
Fantastic. Thank you so much, Megan. That was a whirlwind trip. There's some fantastic information in there. Just to point out that we will be supplying all of the slides from today for all registrants, as well as the videos will be uploaded to YouTube. So you will be able to go back and revisit all of this information and share with your colleagues, please. So from here, what we thought we would give you is really 6 key tips of things to go back and consider in your workplace, and just see where you sit with these things. So Megan's talked a lot about physical distancing today. So making sure that we've got those 1.5 meters between our patients. Having a think about how many staff you've got sitting at the reception desk, and have you got the ability to even put some distance in there, and having staff working maybe inside rooms if they're answering the phones. So you're actually minimising that exposure of staff to potential COVID positive patients. We need to make sure that we're following the guidelines and wearing the appropriate masks for the procedures that we are conducting. And again, practice our good hand hygiene and other hygiene. So making sure that, you know, that's not just for the staff, but also for any visiting allied health or other services that you might have come to your organisation, as well as our patients. Really one of the big scenarios that we need to consider, and Northern Queensland PHN can certainly help you out in this space, is have you got accurate, up-to-date, easily accessible electronic records that in the event that your practice was shut down due to COVID, that you would be able to have your clinicians continue working and you'd be able to implement that really quickly. So what are you doing in the e-health space and your digital records? Have you got those systems set up? So please consider that one. We also need to avoid those interactions in enclosed spaces. So Megan's mentioned a lot around air exchange and physical space today. Have a think about, is there an opportunity that you might be able to do some of your vaccine clinics outside? Obviously, making sure that privacy is covered, and that, you know, it's a safe workplace for not only staff but patients visiting. But have a think about that. Or could you move some of your procedures to a larger room space? Have you got open windows that you can have, etc.? So think about that. And the really big one that we need to take away is the modelling suggests to us over the coming months that at least 30% of the workforce at any one time will be off due to COVID. So when we consider this, in a primary healthcare, we know we are already strapped. You know, we're literally hanging on by our fingernails at the moment for a number of different reasons. And so, you know, our workforce is strained. So do you need to consider having some workforce bubbles so that, you know, you've got maybe 2 or 3 teams that work together so that if one team is exposed, you can continue operating. So have a think about that in your workplace, and is that feasible? And if so, start thinking about implementing that. You'll see on your screen there's 2 really great resources. One, they're both Queensland Health resources, and they are specifically around how you can help keep Queensland COVID safe and keeping your workplace clean and healthy during COVID-19. So if you haven't accessed those resources, certainly jump on there and have a look at those. One of the things we did want to talk to briefly this afternoon is the hierarchy of controls. We get a lot of questions in the helpline around what PPE should I have, how much should I have, what should I be wearing? And I've noticed, which we'll address in a minute, Megan, there's already a question around PPE in the chat. As you can see in this diagram here, when we talk around the hierarchy of controls, which Megan has talked through every level of this afternoon, you can see there that our PPE is considered to be the least effective control measure that we could put into place in the current environment. In saying that, it's the one that people tend to go to all the time. So we really do need to consider what are the other strategies, systems and processes that we need to put in place. So when we talk about elimination, we know we're talking about immunisation and the additional protection that that can give us. But again, like Megan said, we should be asking the screening questions of every single person. We've got a number of tools out there now that when a patient books, it asks them the screening questions. But if you've got a patient that's booking weeks out, we need to make sure that that is being re-asked potentially the day before and on their entry into your organisation. Things can change very quickly with Delta. And so we need to make sure that everyone is asking every time. What can we do in regards to substitution? So replacing the hazards, we really need to be avoiding those aerosol generating procedures. So spiros, we should not be doing spirometry in the current environment. So, if you're doing those, you need to actually have a look at the guidelines, which suggest that that is not a good choice of procedures currently. And again, if we've got some high-risk healthcare workers, how can we reassign the work that they're doing so that they're not at that exposure? So about engineering controls, so isolating people from the hazard. Megan spoke around your design of your organisation. Do you have separate entry and exit points? So what is your workflow? Have you got those 6 to 8 air exchanges an hour? And if you're not aware of these, then that's a job to for your managers to contact your building owner or manager, or whoever your building arrangements are through. We're seeing more and more practices in high-rise buildings. So you've also got to think about things like shared lift spaces. What does that look like? And again, have you got the ability to have windows open? We never used to do that, but certainly now it's become almost a default that you walk into a room and you open those windows for that fresh air. And then again, some of our administrative controls. Have we got up-to-date policies and procedures that everyone is across, not just at time of induction, but it's something that they need to be revisiting regularly? And who is responsible for updating those policies and procedures as things change? We've been warned for probably 6 weeks now, 8 weeks in Queensland, how the virus is coming. Our borders are opening and it is coming, and we need to be prepared. We're starting to run out of time. So if we don't have these mechanisms in place now, then we are at risk of that continuity of business. So have a think about all of those things. And then last, like we said, Megan's already spoken to the N95 and P2s. They must be fit tested and fit checked every time. We know that anyone with facial hair will never get a seal from an N95 or a P2. So it's just not an appropriate form of PPE. So then we've got to consider what are those other controls that we can put in place for these sorts of people. Maybe they are going to be doing all video conferencing and not seeing patients face to face. So think about all of these sorts of things. There is a huge amount of resources out there for you to access. So the next couple of slides, we've got some of the Queensland Health and Department of Health resources, as well as the RACGP. So please, when you get these, jump on and access them. There's lots of videos around PPE. There's lots of policies and procedures and workplace guidelines for healthcare settings. So jump on and access them. They're constantly being updated. So my only request to you would be, if you download and print, set a reminder to check regularly. It's crazy how quickly things are changing with these sorts of documents at the moment. And we acknowledge that it's very hard to keep up to date with them, but it is really critical. because, being out of date could be the situation that, causes an exposure. So just keeping those sorts of things in mind. And again, the RACGP ones, so these are very much focused on general practice and providing those guidelines around infection control procedures and the principles for you and for your team, as well as obviously our office-based practice of infection prevention and control standards. So make sure that you jump on there. RACGP does also have a lot of guidelines around your pandemic plans and managing them. So a worthwhile resource to consider there. Locally, you are very lucky in Northern Queensland in that the PHN has got a significant amount of resources available to you. So we have the health pathways, which are, have become a critical part of a business and what we do. There are pathways specific to managing COVID positive patients and COVID in general. So please make sure that you access those. In regards to digital health resources, Northern Queensland has a page specifically for that on their provider hub. So that's around you supporting you in your digital health in primary care and making sure that you've got your systems and processes set up. We talk around telehealth all the time, but the reality is it's video conferencing that is the preferred method. So have you got all of those services set up? Because an unsecure network, so a Skype, is not the way to go in this scenario. So making sure you're meeting all of the standards in that space. And the other component that North Queensland has is they have a COVID-19 specific website for healthcare professionals. So please jump on there and have a look. If you haven't already subscribed to the GP COVID updates, that is an email update that is recommended that you subscribe to. It's not something that you're going to get a barrage of information from. It is whenever there's critical information that needs to be shared. So that is really something that's important for you to be across and having that support from your PHN. Also, you can see there if you've got any specific inquiries around COVID-19, that there is the preparedness and response at nqphn.com.au email that you can access and email the team and they will get back to you. Just a point to keep in mind, the PHN is currently preparing a pulse survey around preparedness for disasters that will be coming out to all of you for you to complete in order to look at what support is required or needed in this space. So please keep your eye out for that from the PHN. I think that's just about it from me. What we might do now is we'll go over to some of the questions that we've got, Megan. We've got about 7 minutes left. You'll see on your screen there is a QR code that you can jump on and do the survey for us, please. As I've mentioned a number of times, today has been funded by Northern Queensland PHN, and certainly we really value your feedback from today so that we can look at what other opportunities or education that you might require moving forward. So please, whilst we go through some of the Q&As, if you could attend to that, that would be much appreciated. If anyone does have any other questions, please feel free to pop them into the Q&A box. The first one, though, that I'm going to throw to you for, Megan, is there any guidance available about how many masks and other types of PPE we should have on hand?
Oh,
the $1 million question.
It is the $1 million question. How do you actually determine that? Now, I think it's probably important to say at the outset that ordering your PPE stock is one strategy in your COVID preparation and your arsenal, and that we need to consider that in the context of other measures as well. So you should certainly be ensuring that you've got adequate PPE for standard precautions, and with the ability to respond to having to implement transmission-based precautions based on what's happening in the community, and if that is actually escalating. Now, each practice, each business will be different, and it really will be about services, the throughput of your patients, and your environment, the whole lot. But there are actually some PPE burn calculators There's quite a good one from the CDC. There's also another one from one of the companies, but they actually allow you to be able to determine what your requirements will be, regardless of your healthcare setting. So we can add that to the Q&A so people can actually explore those tools and see if they're useful for you to determine what PPE you need to for your practice. But I would certainly be setting out, and planning for a number of days to get you through until you can procure more. So it is really important that you shore up your procurement lines so that you have got ready access in the event there's an escalation and you need to get hold of PPE quickly.
Excellent, thank you, fantastic answer. The next one is, I've got a couple of questions that have been submitted prior to the workshop. One of them is a bit of a statement and then a question attached to it, and that is that we're not seeing many practices in Northern Queensland currently using sneeze guard screens, so the Perspex screens up at reception desks and in pharmacies, etc. Would you recommend having screens installed at reception desks, etc., and should we do it now rather than later? So it's sort of a double barrel. Would you recommend them, and if so, when should we be doing this?
Yeah, I think again they're one measure in terms of the hierarchy of controls. Currently, the Australian advice is that they're not necessary to install a screen between healthcare workers and patients, but there are many international and local authorities such as the World Health Organization, CDC, OSHA, but also WorkSafe here in Australia, actually considers that installing a physical barrier, if feasible, is actually part of your suite of engineering and hygiene controls, perhaps where physical distancing may not always be possible. So the aim of a screen is actually to intercept those respiratory droplets that transmit the COVID virus, but also where you might have non-conformance with physical distancing. So that might be users who are unwilling to physically distance, or perhaps they're just simply forgetful. But also it can help to reduce the reliance on masks, particularly where we go through periods of shortage or where there are user comfort issues. So I believe it's a good measure. I think you need to be prepared. Certainly my experience in primary practice here in Western Australia is that they're up. They're part of the measure. But remember, they're not foolproof. They are a fomite, they're an inanimate object, and therefore they're there as a barrier, so that means they get contaminated. So they need to be routinely cleaned and disinfected. There are some specifications around screens, and we can actually put that onto the Q&A, Sarah, if you like.
Excellent. Yeah, that'd be great. Yeah, I work in a general practice on the Gold Coast, and I must say they're everywhere here. I think some people love them and some people hate them. I'm not sure that the oldies like them because they find them very hard to hear through. And so it does take an adjustment, but certainly we installed them because we found that people were not abiding the lines on the floor that said, please stand back here, and encroaching on space. And certainly it just gave that, almost that barrier that's, stops people from leaning over the desk, dare I say. So thank you for that. Now we've got a couple of minutes and I just want to quickly try and throw one more question in there, which is, what do we do if we have a positive case? Okay.
So we'll look at it from the perspective of being a positive team member or a positive patient. So if you have a person who has been in your practice or your business or your workplace in the 48 hours prior to them developing symptoms, then you'll certainly need to contact your local PHU, your public health unit, to get instructions on managing exposure to other patients and staff. That's if they've not already been in contact with you. But the actions that will be required will really depend on a number of variables. And that includes whether the patient or the team member, actually, when they last attended the practice or they last worked, the nature of the appointment or the work that they actually perform, and the interaction that they've had with others. So if you've got good documented processes and good monitoring processes, even things like security cameras, having your roster and work allocations, all of that information is actually critical to be able to do an assessment to determine what actions are actually required. Obviously, if the affected person has not been in the practice or the workplace in the 48 hours prior to developing symptoms, no further action may actually be required, but you will be guided by the public health unit in response to that. If the person tests positive, then they're going to have to self-isolate and therefore not return to the practice until they actually meet the criteria for release from isolation. And that'll be in accordance with the current version of the CDMA guidelines.
Fantastic. Thanks for that, Megan. So that brings us to a close for this afternoon's workshop. As I mentioned earlier, today's session, as per the previous sessions, have all been recorded, and either late today or Monday, they will be uploaded to YouTube, and all registrants will be shared with the presentation. So you will receive all of those. If you may have missed a section, or you actually just want to go back over and look at some of the links. So on behalf of APNA and Northern Queensland PHN, we would just like to say a thank you to everyone for joining us today, and all those clinicians and admin staff out there that are working tirelessly to keep everyone in Northern Queensland safe and well. So thank you for joining us, and we will see you next time. Thanks for that, Megan. Bye, everyone.